all for this webinar of the SSBMT. And today, our topic will be to talk about recent and shed the light on the thalassemia management. So recent update in thalassemia management. And we have great speakers today who will talk about different parts of the topic. Starting from Dr. Farj Al-Qahtani and going through Dr. Demetrius Pharmakis and Dr. Sultan Al-Mutairi. And we'll go back to Prof. Farja again in the last speech. So we have 4 talks. Each will spend like 10 to 15 minutes. And we'll have discussion at the end. So please be with us and prepare your questions for the end. Before we start, I would like to thank our sponsor, Newbridge Pharmaceuticals, for sponsoring this webinar. And as you are aware, SSBMT adopted to have this webinar almost every Saturday evening. So to get your attention and to the latest updates in hematology in general. Okay, so I think to start with, I would like to, do you have the program? Yes. So I would like to introduce Prof. Farja Al-Qahtani. Dr. Al-Qahtani is well known to our hematology community. She is a professor of internal medicine, hematology consultant, and director of lymphoma fellowship program at King Saud University College of Medicine. So, Prof. Farja, the floor is yours. She will be talking about thalassemia, the hidden faces. Ready? You're mute. Okay.
Okay. Assalamu alaikum. Need my slide?
Yeah.
Okay. Thank you, Prof. Al-Askar, for nice introductions, and good evening, everyone. So my topic will be in 10 minutes about the thalassemia, the hidden faces, which lays not only in its clinical burden, but in the silent, emotional, and social and lifelong challenges and its impose on the patient and family. And before we do that, we have to understand the structure of hemoglobin and how it's altered in case of thalassemia. As all we know, the hemoglobin is composed of 4 proteins of globin, 2 alpha and 2 beta, and they are balanced. And the main job of it is to carry oxygens and through the lung and deliver it to the tissues. Once these RBC are hemolyzed, and they critically recycling the iron in the erythropoiesis. But in case of thalassemia, there is altered an imbalance between alpha and beta globulin, which is lead to oxidative damage and hemolysis, ineffective erythropoiesis, leading to anemia and iron overload. And this is the essence of thalassemia, of different type of thalassemia. So in case of alpha or beta, both of them, there will be excess of alpha chain in case of beta and the opposite. And these lead to ineffective erythropoiesis and intramedullary apoptosis in the bone marrow and hemolysis in the spleen. As these carries on different types of spectrum of thalassemia, starting from thalassemia trait or beta thalassemia minor to the extreme part of thalassemia where they are lifelong transfusion dependent. And this is just to show you that even with sometimes with non-transfusion dependent, they might require from on to on some types of transfusions. And this is not only in clinical burden of these patients from the disease by itself causing a lot of complications like facial, bone deformities, liver cirrhosis, endocrine, growth retardation, thrombosis, cardiac failure, and maybe also as a treatment related when case of patient, they will have splenectomy, frequent transfusions, and iron chelating therapies. So in both sides, they will have complication, whether from the disease per se or from the uh, treatment related. And this is real data from patients from Saudi Arabia and from the United Arab Emirates. They are they illustrated the complication from the disease or from the burden of a treatment, like patient, they will have recurrent infections, delayed in the growth, iron overload, frequent transfusions. For both experience in these patients, they are from the disease or related treatment. And this is not only in a transfusion-dependent thalassemia, it's also complication can be seen in non-transfusion-dependent thalassemia. As a result, this is a beautiful diagram. It's Venn diagram, whereas when there is an effective erythropoiesis, there will be gallstone, osteoporosis, and thrombosis, leg ulcers, and they are overlap with other complication. If patient have iron overload, that means they will have liver disease, decrease in neuronal function, and osteoporosis. At the end, all of them, they share the complications of those patients. So non-transfusion dependent is not a milder form of thalassemia. It's carry its own complication too. And in this study, they look at the health-related quality. And as we can see, the vertical line, it's a zero, the red when it's pointed, and the highest for healthy adults around 84, the health-related quality of life. And we can see patient with thalassemia and mainly transfusion dependent, the health related quality is really bad. It's around 69%, where we can see there is no big difference from other chronic illness, especially like cancer. Still, they will carry a poor life quality of life. And here we have comparison between transfusion dependent and non-transfusion dependent as a health of quality of life. We can see the non-transfusion dependent, did worse in the physical function and general health in those patients. So non-transfusion dependent is not a benign or milder form of thalassemia. Also, those patients, one of the hidden, and maybe we forgot a lot in our clinical practice to ask those patients, the pain, generalized pain in different area. As they grow older, they will start complaining of a chronic pain, mainly in the lower back, but they can have a pain anywhere. And this is beautiful. It was a global review about in developed and developing countries about the unmet need for those patients. And it's focused in two parts from the blood issues like blood processing, safety for blood, availability for blood, as well the important of having guidelines, a social life, and the health of these patients. This is very important in need of like expert centers, expert hematologists, and providing a multidisciplinary care for those patients. And we can see it's almost the gray one, it is the total percentage of the survey responded. And there is absolutely unmet need for to have these. And we can see some of them, there is 100% all patient in developed and developed countries, they agree on it. And we know the relation between pre-transfusion hemoglobin level and the rate of mortality rate. And if the hemoglobin pre-transfusion is above or higher 9.5, the association with lower thalassemia related mortality is higher. And from the graph, we can see the level of the hemoglobin, the lower the hemoglobin, the mortality rate is very high. And it's same for non-transfusion dependent also. The survival, morbidity-free survival is higher with those patients having high hemoglobin level. 10 is more than when they have lower level. So non-transfusion dependent, we need to focus on it and not to look at it as a milder form of thalassemia. And usually in the study of thalassemia, we can focus in the clinical trials. They always emphasize in the 1 gram increase in the hemoglobin is very important, like Energize study when they did it. And the importance of this 1 gram of deciliter of increased hemoglobin, it is independently associated with 0.7 decrease in the number of morbidity. And this is very important considering the patient high mortality with the level of hemoglobin. And in later in the years, we understand the non-transfusion dependent on this cohort study, when they follow a patient for more than 10 years, we have almost 14% of those patients, they phenoconversion, and they started to be transfusion dependent later in life. And this is dependent on the hemoglobin level, comorbidity, need of iron deletion as chelating agent, as a risk factor for the conversion. But there is no doubt we have need and unmet need for patient for the surface multidisciplinary approach in thalassemia patient. We need expert hematologists, center for hemoglobinopathies, expert in thalassemia. Specialized nurses are trained how to deal with these patients, especially from the transfusion part. Cardiologists, endocrinologists, need to be involved with us. Also, the psychologist and social worker, those patients, they have a defect in the quality of life and the physical activity. Obstetrician later in life is needed for those women, and absolutely the dental care. But there is no doubt a multidisciplinary approach for those patients is unmet need in the future to establish a big center is needed for them. Thank you.
Perfect, Prof. Farja. This is excellent introduction to the disease, highlighting the burden of the disease and the various complications. And we shall proceed with our program. We'll leave the questions to the end. So our next talk would be further into the complications, cardiac complications, at the heart of multidisciplinary discussions, case-based approach, and will be presented by Professor Dimitris Pharmakis, who is a professor at the University of Athens Medical School, Thalassemia and member of Thalassemia International Federation. So, Dr. Dimitris, ready? The floor is yours. Please go ahead.
Thank you very much. Thank you, Professor Alaskar, for the nice introduction, and thank you for the kind invitation to this very interesting, I think, webinar covering all the timely aspects of the management of thalassemia. I would like to thank the SSBMT and also the Newbridge for the kind invitation. This is an outline of my presentation. I will not start actually with the importance of MDT in the management of thalassemia, because this topic was very nicely covered by the previous speaker. So as we know, thalassemia is a multi-system disease affecting many systems, as nicely shown by the previous speaker. And this comes from a very recent publication based on a Greek cohort. The transfusion-dependent patients here are in blue bars, so you can see that there is a wide spectrum of complications affecting the cardiovascular system, endocrine, hepatic, the liver, the kidneys, neurological complications, musculoskeletal complications, and so on. So it seems that the majority of patients, the vast majority of thalassemia patients, 71%, had at least two comorbidities, while 41% had at least 4 comorbidities. So comorbidities are very, very often in patients with thalassemia, and this is why multidisciplinary care is an indispensable part of the management of patients. This comes from the TIF guidelines, showing in the center of the care the thalassemia patient, the thalassemia specialist, and around them a wide spectrum of different specialists, the endocrinologists, the pathologists, gynecologists, reproduction specialists, diabetologists, psychiatrists, psychologists, and so on. Of course, the cardiologists. That's why I'm here today. So coming to the cardiac complications. What is the impact of cardiac complications in patients with thalassemia? As you all know, heart disease have been the leading cause of mortality in patients with thalassemia. And this is data from three different cohorts in different time points. You can see that in all cohorts, the heart disease was the cause of death in 60 to 70% of patients. Well, of course, things have changed over the past decades. There has been a tremendous evolution in the care of patients, and this has led actually to a dramatic improvement in survival. And now, in regions where there is access to all those therapies, patients tend to have a normal lifespan. Of course, there are also problems related to aging, but we will come back to this later. And this comes from a Greek thalassemia registry, hemoglobinopathy registry. And in this panel, you can see the drop in the mortality of patients with thalassemia. And at the same time, there is a drop in the cardiovascular mortality, or the cardiac mortality, or the death from heart disease. And you can see that these two, let's say, rates of decline are parallel. So a decline in the cardiovascular mortality led to a similar, a parallel decline in the overall mortality. And this is because, of course, cardiovascular disease has been the leading cause of mortality. So by treating properly the disease, the main disease, we prevent and we treat cardiac complications, and this leads to a dramatic improvement in survival. Now, in cohorts with access to proper care, the incidence of heart disease, or the prevalence of heart disease, is quite low. You can see it's around 9% in this a series of patients from Cyprus. Now, what are the forms of cardiac complications in patients with thalassemia? This is a meta-analysis of different studies published a few years ago. And you can see that the main complications are heart failure with systolic dysfunction or with diastolic dysfunction, with both, pulmonary hypertension, particularly for patients with thalassemia intermedia, and arrhythmias that can be combined with all the other cardiovascular complications. And this is a diagram showing the pathophysiology of heart disease in patients with thalassemia. And of course, it all starts with the hemoglobin defect, leading to ineffective erythropoiesis, to hemolysis, to anemia, and then anemia leads to high output state and to some degree of iron overload, but necessitates transfusions, and transfusions lead to significant iron overload. And of course, there is splenectomy somewhere leading to thromboembolic complications. And you can see that anemia, iron overload, let's say somehow orchestrate the whole spectrum of cardiovascular pathophysiology and cardiovascular complications, including heart failure, arrhythmias, thromboembolic complications, and pulmonary hypertension. So I will show some illustrative cases. This is a patient with thalassemia intermedia, actually treated in our center many years ago, around 20 or 25 years ago. This was a 65-year-old thalassemia intermedia patient. She has been splenectomized. She was not on regular blood transfusions, but on occasional transfusions only, with no chelation. And you can see the low hemoglobin level. The patient was in heart failure, but with a good ejection fraction, a high ejection fraction, actually, with a high cardiac output, so what we call a high output heart failure, and of course with significant pulmonary hypertension. You can see here some tracings from the echo and the pulmonary catheter, the tricuspid gradient showing pulmonary hypertension. And of course, the consequence of all this severe anemia was where the extramedullary hematopoietic masses in the thoracic cavity to compensate for the untreated anemia. So the problem in this particular case was actually the low hemoglobin level, the lack of treatment for anemia. Of course, there has been improvement in this in terms of thalassemia intermedia, and this is our two cohorts of patients with thalassemia intermedia, one with 20 years apart. And you can see that there is a decrease in heart failure, a decrease in pulmonary hypertension, particularly the severe pulmonary hypertension. And this, of course, came because of the use of transfusions in this particular population and coupled with chelation therapy. Coming to thalassemia major now, this is also a case treated many years ago in our center. It's a 30-year-old man, thalassemia major. He had been splenectomized. He was on regular blood transfusions, but inappropriate iron chelation therapy with a good hemoglobin level, pre-transfusion hemoglobin level of 9.5, but a very high serum ferritin, around 5,000. Again, in heart failure, but now with reduced ejection fraction of 25%. You can see the dilated left ventricle with secondary mitral regurgitation, severe diastolic dysfunction. And of course, the problem here was the high serum ferritin, the lack of proper iron chelation therapy. And I will show you now two contemporary thalassemia patients. First, a woman with thalassemia major, 50-year-old, on regular transfusions and iron chelation with a good hemoglobin of 10, a serum ferritin amount 480. Some occasional palpitations that have been related to paroxysmal atrial fibrillation. I will come back to this later, with good ejection fraction, no pulmonary hypertension, and with MRI showing no iron overload in the heart or the liver. Very similar case, 64-year-old woman, thalassemia intermediate now, but on regular blood transfusions since the age of 24 years, with chelation, good hemoglobin, very good serum ferritin, no symptoms, good ejection fraction, no pulmonary hypertension, and lack of iron in the heart, iron overload, iron load in the heart or the liver. These are two contemporary cases, one with thalassemia major and one with thalassemia intermediate. You can see here that there is the good treatment of the main disease with regular blood transfusions, proper iron chelation therapy, and no iron overload in the heart or liver. And actually the heart disease in patients with thalassemia followed the evolution of thalassemia treatment. And before the regular blood transfusions, or in patients with thalassemia intermediate not treated properly, there is a high output heart failure leading to cardiovascular mortality. Then we move to the second era, where patients were regularly transfused, but with no proper chelation therapy, or still contemporary patients with no proper chelation therapy. These patients develop iron overload cardiomyopathy. And we come to patients that have both good transfusions and good iron chelation, and they have minimal or no heart disease, but they may develop some age-related complications because of their aging. And I will come back to this later. And also a couple of other cases showing some sporadic cardiovascular complications, just to show you how wide is the burden of cardiovascular disease in these patients. The problem here in this 35-year-old woman was an ischemic stroke. It was a thalassemia major patient treated many years ago in our center on regular transfusions with not very good iron chelation. Actually, good hemoglobin, not very good serum ferritin, but heart failure with an impaired ejection fraction and atrial fibrillation, and the patient developed an ischemic stroke. And of course, the problem here was atrial fibrillation that caused the ischemic stroke. And besides stroke, of course, there is a wide spectrum of thromboembolic complications in patients with thalassemia. There are more common patients with thalassemia intermediate compared to patients with thalassemia major. And the risk factor, of course, is splenectomy, very important, aging, and other thromboembolic complications. Another case, sporadic case, again, a patient with thalassemia intermediate, splenectomized, occasional transfusions, no chelation, a low hemoglobin level, some symptoms of heart failure with preserved ejection fraction and high output, again, heart failure, and the patient developed a subarachnoid hemorrhage. And the problem here in this particular case was these angioid streaks. What are the angioid streaks? There are breaks in the elastic lamina of Bruch's membrane in the fundus that may cause actually a loss of vision. But these indicate the presence of an acquired elastic tissue disorder that we observed in patients with thalassemia, particularly elderly patients with thalassemia intermedia without transfusions. And this disorder resembles the hereditary pseudoxanthoma elasticum with cutaneous lesions, ocular lesions, as I said, the gioid streaks, but also vascular lesions causing calcification, but also a bleeding tendency because these vessels may rupture more easily. This was just to show the spectrum of complications. Of course, we see less and less now with the proper treatment, including patients with thalassemia intermedia. What are the emerging challenges nowadays? Well, the main challenge that we face in regions where patients have proper care is the aging of population. Of course, aging is a good thing because it shows that there is a dramatic improvement in the management of thalassemia. This is from a center in Nicosia, Cyprus, the capital of Cyprus, and you can see that within 20 years, within 10 years, there was a significant increase in the median age of patients from the 30s to the 50s. And this is also the case in many other cohorts. And with the increase of age, there is also an increase of age-related complications, of comorbidities. Well, the ager, the older the patient, the higher the prevalence and the incidence of comorbidities. And as you can see here from this Greek cohort, so we published this a few years ago with TIF, the changing epidemiology both of cardiovascular disease and of the comorbidities of the patients because of the aging of the population. And in terms of cardiovascular disease, there are specific age-related cardiovascular conditions like atrial fibrillation, as in one of our contemporary patients, one of the cases that I described earlier, aortic stenosis, and we have patients that required actual aortic valve replacement, and also a form of heart failure, which is very typical in the elderly heart failure with preserved ejection fraction, not because of high output heart failure, because of anemia, but because of aging. And of course, in the problem, there are different, mechanisms leading to atrial fibrillation, which is the incidence is very high in patients with thalassemia, but the elephant in the room actually is aging. And of course, atrial fibrillation increases the risk of stroke, as we saw in the previous example. And of course, there are other cardiovascular challenges like the cardiovascular complications of curative therapies with the conditioning regimens. For example, for the hemolytic stem cell transplantation, we may have cardiovascular toxicity, and we have a higher cardiovascular risk if the patient has iron overload, significant iron overload, because before the curative treatment, this is maybe actually the problem with gene therapy that may occur later in life than compared to hemolytic stem cell transplantation. So coming to the final part of my presentation, what is the cardiovascular assessment nowadays? Of course, we need a regular cardiovascular examination with clinical examination, ECG and echo every year for all patients. And then we also need the T2 star imaging in transfusion-dependent patients, ideally every 2 years. And if we have cardiac problems or any new symptoms or change of symptoms suggestive of potential cardiovascular disease, we need to repeat immediately the cardiovascular assessment. This is part of the multidisciplinary care of patients. And of course, monitoring and networks, proper monitoring and network of patients, of centers may improve the care of patients. This is the example of the MIOT registry in Italy. It is a network in Italy. It is a network of thalassemia centers and MRI labs performing MRI for iron overload. And you can see that the treatment of patients within this network helped significantly improve the chelation therapy, the control of iron overload, and the cardiovascular and overall outcomes of patients. So networking and proper, care, multidisciplinary over networks helps a lot. There are advances also in cardiovascular imaging, like the myocardial strain, that we can help find subtle cardiovascular abnormalities. And of course, the MRI, just for iron, we can use it for the complete assessment of the cardiac morphology and function, with also the characterization of the myocardial tissue. And the more parameters we have with the MRI, the greater diagnostic value we have. So the management overall of thalassemia now, it's also it is based on the main pathophysiology of the disease. So treating anemia with transfusions, treating iron overload with chelation, and treating the different complications, the different comorbidities with multidisciplinary care. This is the best treatment to prevent and manage cardiovascular disease. Of course, in patients who develop heart failure, who develop cardiovascular complication, we have also cardioactive medications and special cardiovascular treatments, but the main treatment of cardiovascular disease is the treatment of the main disease itself. We need to keep the pre-transfusion hemoglobin level above 10 to maintain the absence of iron overload in the heart, with the T2 star above 20 milliseconds. And then, of course, if there are problems in the heart, we need to intensify our chelation therapy, to start cardioactive medications, and to try to reach these goals and improve, of course, symptoms and cardiac function. We have new drugs for the heart, new drugs for heart failure, for example, like the SGLT2 inhibitors now. They used to be they started as anti-diabetic agents, but now there are mainstay treatment for heart failure across the spectrum of heart failure, so regardless of ejection fraction, and also to prevent heart failure in patients with diabetes and chronic kidney disease. So all patients with thalassemia who have either diabetes or chronic kidney disease or heart failure should be described these medications. And of course, we have new contemporary cardiac interventions to treat heart disease, and we often need to replace the aortic valve in the aging thalassemia populations. And this is the ablation for atrial fibrillation, and a mechanical treatment for this very common arrhythmia becomes more and more frequent in patients with thalassemia because of aging. And of course, we have new domains in cardiology that may deal with the cardiovascular complication of curative therapies. We have the domain of cardio-oncology now, taking care of patients who have chemotherapy and myeloablative regimens. And of course, last but not least, we're going to hear a lot about these innovative therapies in the next presentations. We have the innovative therapies like the curative therapies, gene therapies, and the new drugs, luspatercept, mitapivat, that have tend to change the overall management of patients with thalassemia. And with mitapivat, for example, we know that a good percentage of patients will have an increase in hemoglobin level in case of non-transfusion dependent patients. And also in another study, the ENERGIZE-T trial that was also announced, again, patients with thalassemia major become a percentage of them became, there was a significant drop actually in the transfusion burden in these patients, who treating anemia with alternative methods like mitapivat help also the heart. So coming to my conclusions, thalassemia is a multi-system disease with multiple complications, need for multidisciplinary approach, as the first speaker nicely shown. The decline in cardiovascular complications because of modern therapy and mortality led to a similar decline in overall mortality, where patients have true access to proper care, which is not the case, as you know, everywhere in the world. The forms of cardiac complications have evolved in parallel to the evolution of thalassemia therapy, but with the aging of the thalassemia population, which is a success of the current treatment. We have new cardiovascular challenges that we need to face. And of course, recent diagnostic and therapeutic modalities may improve further cardiovascular disease and the overall outcomes of patients with thalassemia. And last but not least, the regular cardiovascular assessment is an important part of the multidisciplinary monitoring. I just want to say in 1 minute that I have been visiting the Saudi Arabia for some time now, and I have been impressed with the tremendous initiatives, the innovative initiatives that the KSA follows. I visited the Ministry of Health in December in Riyadh. We discussed this transformation program of the health sector, I visited the National Health Command Center, the SIHA Virtual Hospital. We talked about the MOJA project for thalassemia with all these different modalities, national registry, screening program, vaccination programs, through multidisciplinary care, the IHBD summit in which I also participated in last February, and of course access to curative therapies. And actually, KSA was the first country to approve mitapivat in thalassemia, and also the recent publication of the Saudi concession statement for the care of thalassemia patients that we contribute also through TIF. And I think that all those innovative, let's say, initiatives promote the equitable access to good care for all patients with thalassemia in the country. Thank you very much for the invitation and for your attention.
Thank you, Prof. Pharmakis. This is elegant talk, and it exemplifies actually the importance of the multidisciplinary team. Being a cardiologist with focus on thalassemia complication on the heart, I think that excellent example of better management and preventive management to deal with complications and to prevent complications of thalassemia, which is major impact again on the health of our patients. So thank you for again finishing on time and moving on with our program. And just to remind our attendees, please post your questions at the Q&A section. To be ready for the discussion, please. Our next speaker is Dr. Sultan Al-Mutairi. Dr. Sultan is a consultant adult hematology and BMT at Princess Noura Oncology Center, King Abdulaziz Medical City, Jeddah, the Western region of Saudi Arabia. So Dr. Sultan will talk about the novel approaches in thalassemia management. So the floor is yours, Dr. Sultan.
شكرا دكتور، الله يعطيك العافية دكتور أحمد. Thanks for Newbridge for the chance to meet all of you and talk today about one of the common disorder we have in the kingdom, which is thalassemia. So my talk will be about one therapy, which is actually gene therapy. Thalassemia is one of the common disorder we have in the kingdom after sickle cell disease. And until recent, the only option was bone marrow transplant for cure, and it was mainly done in pediatric population because of better outcome, while in adults the outcome wasn't great as in pediatric. So this is my disclosure. So as I mentioned, it is the second to sickle cell disease. It has many mutations, actually more than 1,200 mutations leading to different phenotypic presentation. We have non-transfusion dependent thalassemia, and we have a transfusion dependent thalassemia. And the focus today will be the transfusion dependent thalassemia, which is prevalent in the kingdom, and also it has the burden on the patient themselves and the economic burden about on the blood banks, especially requirement for red cell transfusions. So the beta thalassemia, it's prevalent in the Mediterranean countries, the Middle East, Central Asia, India, Southern China. And the highest carrier frequency is reported in Cyprus. There is estimated around 1.5% of global population that are carriers of beta thalassemia. And worldwide, the incidence of symptomatic individuals around 1 in 100,000. So the prevalence in the kingdom is around 18.5 per thousand person examined, around 18 for carriers and 0.5 for cases. And if you look about the geographical distribution of these cases, we see the Eastern region still have the highest prevalence of sickle cell disease, the highest prevalence of thalassemia. Also, we see other cases in the southern region. This is the second also in both for sickle cell disease and thalassemia prevalence. This is followed by the western region, central region, and the least was in the northern region of the kingdom. So this slide it's about fetal hemoglobin. So these patients usually when they are born, they are protected by presence of fetal hemoglobin that does not have a beta chain, but does not last for longer time. So up to 3 to 6 months, the levels of fetal hemoglobin decline very quickly. And hemoglobin F, it is one of the really modifier of severity with patient with thalassemia and sickle cell disease. So when you tend to have higher levels, you tend to have less severity of the disease. And one of the key things that regulate hemoglobin F is the BCL11 genes, and which is the potential now target for gene therapies to induce very high levels of fetal hemoglobin. If you look here, this is studies where they looked about how the elevation of fetal hemoglobin compared to morbidity. So whenever you have higher level of fetal hemoglobin, you have more protection from morbidity from thalassemia in general. And there are spectrum of complication that was discussed in the Prof. Farja presentations about the complication of thalassemia, whether non-transfusion dependent thalassemia or transfusion dependent thalassemia. So this will just take you a little bit in history. We'll look back about the first successful allogeneic transplant for beta thalassemia was in the 1981. There is some developments which wasn't like very quick. It was kind of a bit slow until with the 2003 was the first regulatory approval of genetic therapy. In 2010 was the first case report of successful gene therapy for patient with transfusion-dependent thalassemia. And this is paved the way for development of FDA-approved gene therapy like Zentelzo or XSL later with different technologies. So how the mechanism where these gene therapy happens, either they go with gene addition, adding a functional copy of beta chain using lentivirals. And these all hematopoietic stem cells where the genes are introduced are reinfused in the patient after myeloablative conditioning chemotherapy. The other thing is to do gene editing, trying to target the disease-causing mutation, trying to correct the defective genes. There are two strategies. Either you go for fetal hemoglobin, editing BCL11 enhancer region with different technologies to boost the hemoglobin F expression, or you directly correct the mutation itself. So these are the three molecular targets of gene therapy in general, either gene addition of healthy beta chain, or correction of the defective gene, or hemoglobin F induction. And hemoglobin F induction, it is that's been used most frequently now in gene therapy, especially with the current gene therapy available in the kingdom. With excellent result that we'll go over it. This is just simplified to you how Cas9 gene act, very simplified way. It works like a genetic scissors and the pen to fix the problem at the DNA level. Then the scientists design a CRISPR guide DNA that act like a GPS to find the exact spot in the DNA where the problem is. Then the Cas9 enzyme, which is the scissor, cut the DNA at this location. Then the corrected blood stem cells are infused back into the patient after myeloablative conditioning chemotherapy and waiting for them to produce. So the first one, FDA approval was Beticil, or the trade name for it is Zentelgo. It is approved in 2022. So this is use a lentiviral vector to insert a functional hemoglobin gene into the patient's stem cells. Their primary efficacy endpoint was transfusion independence, hemoglobin of 9 above, and they should be independent of transfusion for 12 months or more. And 37 out of 41 patients really achieved transfusion independence. And this is have seen in different genotypes, whether beta 0, which is severe form, or non-beta 0, beta 0 patients. Hemoglobin restoration around 10 to 12 gram deciliter after therapy. And the long-term efficacy is maintained up to 6 to 9 years follow-up. The second type, which is available here in the kingdom, it is the exocell gene therapy. It's approved in December 2023, and it's used CRISPR-Cas9 gene editing to disable the BCL11 gene and reactivating fetal hemoglobin to rise their levels high. So this trial, it's patients are between 12 to 35 years of age, and they defy transfusion dependence by requirements of 100 ml per kg per year or 10 units per year in the previous 2 years. So their primary efficacy endpoint was transfusion independence for 12 months and more, with maintaining hemoglobin of 9 from 60 days after the last RBC transfusion up to 24 months post-infusion. They looked into other secondary endpoints, the duration of transfusion independence, the total hemoglobin and F hemoglobin levels, and the patient-reported outcomes. And they have the CLIMB 131, which is extension, long-term follow-up to assure the safety of the gene therapy and long-term outcomes. So the eligibility criteria, and this is actually what we apply here in the kingdom so far, age between 12 to 35 years. They should be physically fit to undergo autologous stem cell transplant. As a principle, they should have good performance status, the diagnosis of beta thalassemia, homozygous beta thalassemia, and also the criteria of transfusion and dependency. Now, there are a lot of exclusion criteria. The first one, I would not put it as an exclusion, which is available of 10/10 HLA match related donors. So we really do not adopt this here. So even patients have HLA match as an adults, we take them for gene therapy. I think because the outcomes is really not great as we've seen with patients with sickle cell disease, especially locally. If they have associated alpha thalassemia or more than one alpha chain deletions, as this is kind of a modifier of the severity of the beta thalassemia, any active infection, any significant cytopenia not related to a hypersplenism, if they had a prior allogenic stem cell transplant, and advanced liver disease. So this patient, if they have, they're at risk of liver iron overload and potential cirrhosis. So when their liver iron concentration below 7, they go to gene therapy. But if it's less than 15, we do fibroscan or liver biopsy to make sure there is no fibrosis before taking them to gene therapy, because the myeloablative chemotherapy depends on busulfan, which is really hepatotoxic. Other exclusion criteria, if they have significant bleeding disorder, if they have reduced ejection fraction, renal impairment with GFR less than 60, or there is also a defect in the lung function with DSO less than 50% of productive, if they have prior gene therapy. Now, intolerance to, because we need mobilizer like plerixafor or GCSF, so either any hypersensitivity reaction or intolerance, exclude the patient from going to gene therapy. And by default, if any active viral infection will be excluded from that until the viral infection was cured. Now, this is the baseline characteristic of patients who were enrolled in the clinical trial. As you see, the majority of patients really above 18 years of old, and the majority of patients, they have beta 0 genotype, which is one of the commonest genotype we have in our thalassemia group. If you look about their engraftment after myeloablative chemotherapy, what has been observed is probably more delayed platelet engraftment has been profound in patient on gene therapy, acceptable time to neutrophil engraftments, and this is the time for hospital discharge around 39 days, and the duration follow-up months after XSL was 38 months. And they defined them between full analysis set or primary efficacy set. And this is the list of the patients who are enrolled in the clinical trial, around 54 evaluated patients. 51 of them really achieved the primary endpoint, which is transfusion independence for 12 months. Two additional patients achieved the primary endpoint later, so around 98% would say 53 out of 54 really achieved the transfusion independence. One patient who have significant transfusion reduction, but did not achieve the primary endpoint and became free of transfusion for 8 months. And the median duration of transfusion independence was around 34 months. As you see, their total hemoglobin went up close to normal range. And also the concentration of hemoglobin F as went up inside the red cells. Iron overload, it is a well-known complication of patient transfusion with thalassemia because they require more red cell transfusions. So as in a way of sense, when you are reducing their transfusion requirements, they're less RBC units, it means less iron accumulation. With continued chelation, you will see the serum ferritin will really decline by time. You see the liver iron concentration also decline. So the mean serum ferritin decreased over time to below baseline by month 12, and the liver iron concentration below 5 milligrams by month of 48. And really around 44% have stopped iron chelation therapy. Regarding safety, if you look here in the table, there is no cases that led to death and malignancy and thalassemia. I think there was a case reported in patient with sickle cell disease, which wasn't related to the therapy itself or the XSL. The severe side effects, there are two, which is related to XSL. One is a case of idiopathic pneumonia and a case of HLH. But the main common side effects was mainly due to chemotherapy, basically, febrile neutropenia and headache and stomatitis predominating these side effects. Using busulfan as the conditioning chemotherapy, you expect VOD cases. Around 7 participants had VOD events, and all events were related to busulfan, and all events fortunately resolved after defibrotide treatment without any need for ICU admission or dialysis. And most events occurred in the first 6 months, were decreasing the rates over time. So in summary, now we have another transformative therapy in addition to transplant curative therapy for patients with transplant thalassemia. We have data about the short-term efficacy. We have data about the short-term safety, which is acceptable. We are just need to follow on the long-term data to assess about safety and efficacy on long term. So the main toxicity of gene therapy is related to post-sulfan conditioning chemotherapy. Now, the cost and access across is a limitation. We have two centers in the Kingdom, National Guard Hospital in Riyadh, National Guard Hospital in Jeddah, who are providing gene therapy, but with the hope for expansion across the kingdom, inshallah. And I will conclude my talk. Thank you.
Great talk. Thank you, Dr. Sultan, highlighting the gene therapy and stem cell transplantation as therapeutic options for thalassemia. We shall proceed with our next speaker, Prof. Farja, who was introduced at the beginning. She will talk about across the spectrum of thalassemia, energizing the patient experience. Please, Dr. Farja. Again, to remind the audience, keep your questions or post your questions again for our great speakers, so we have discussion at the end. Yes, please.
Thank you. Hi again. Having understood the disease burden from earlier and knowing the mechanism, we have to now to look for another emerging therapy other than maybe transplant, gene therapy to be much easier in those patients. In recent years, we can see many therapeutic targeted therapy have been emerging. Already mentioned this slide by my colleagues, Dr. Demetrius. So I will move, which have been approved and access approval and very fast track approval for the new therapy. One of them is luspatercept at one time for thalassemia patient, approved by, and it starts to be the standard of care we are using in our patient, majority of the center. Then we have Dr. Sultan mentioned the gene therapy for those patients. And last year, we have metabavate have been approved in Saudi Arabia as well in the FDA, American US FDA. And I think many centers in Saudi Arabia, they were involved in Energize and Energize 2. For luspatercept, it was the key, one of the key trial beyond and life trial, belief trial for those patients, they can be used. And majority of us, we are using. So I will not talk, I will be focused on the new emerging therapy, metabavate for those patients. For non-transfusion study, metabavate, it's a pyruvate kinase activator, have been used for patients with pyruvate kinase. Then we have Energize 2 study. Then now for thalassemia patient, and now we are using an ongoing trial as one of our center as participate on the Rise Up trial. So it's a growing evidence that metabavate, which is pyruvate kinase inhibitors, work in the energy and the RBC like oxygens. So this is where it is mainly working in the ATP and increase the energy of full oxygenation of red RBC. So Energize study is a global double-blind study, phase 3 of metabavate, and the Energize, they look demonstrated for the efficacy and safety in adult patient, alpha and beta, non-transfusion dependent thalassemia. And if we look at the study recruitment, it's a little bit different from Energize T, because the double-blind period for alpha and beta non-transfusion dependent is only 24 weeks. And the primary endpoint was to increase the hemoglobin level by 1. Then the subject will go to open label extension for 5 years follow-up. The exclusion criteria for those patients was patient with hemoglobin C or S, prior exposure for gene therapy, or exposure of luspatercept within the 18 weeks before. So this is mainly the exclusion criteria. Primary point, they increase the response of hemoglobin by more or equal 1 gram in average from the baseline of hemoglobin concentration in 12 and 24 weeks compared to the baseline. The secondary endpoint was to assess the patient fatigue scoring for those patients as well as 12 and 24 weeks. And the secondary efficacy endpoint is looking to the hemolysis and erythropoietic activity, which really I like it in the study because at least we have something objective we can measure the response of those patients. And the safety endpoint was the severity, the type, relation to the adverse event. The basic line of demographic in both group, there was equal the same. It was 2-to-1 recruitment. Alpha and beta hemoglobin H was included. Almost everything was, the demographic is equal almost. So methabapate was demonstrated statistically significant in a 12 weeks improvement in the hemoglobin response with very significant, statistically significant. And we can see in the 12 weeks, they maintain even the response of hemoglobin from 12 to 24 weeks, where in placebo, as we can see, there is actually no response. And here we look for other subgroup analysis for it was also in favoring the metabavate group versus placebo. And if you look to the fatigue score, also patients have been demonstrated there is increase, there is improvement in the fatigue score and the quality of life of those patients as they reported in patients with the 12 and 24 weeks. If you look to the secondary was looking for hemoglobin concentrations, we can see they sustain it. They start to increase from the 4th week and start to maintain the level of hemoglobin until 24th. And this was only during the double-blind period. If we look to the marker of hemolysis, there were also improvement matching the improvement of hemoglobin. So indirect bilirubin start to be decreasing, LDH decreasing, slightly improving in those with significant statistically improvement. The same also the marker of erythropoietic, the retic count was improving. Erythropoietin is measured. There was improvement in those patients. So this is a good where we as a clinician, we would like to see if the improvement was a placebo effect in those patients or there is subjective, objective improvement. Clinically, we can discuss it with our patient. And most important was the side effect. There was a lot of concern using these patients. If there is any grade being reported by the doctors who involved in the trial, if they reported any serious side effect, and the graded was up to 5. And we have, as we can see in metabavate arm, they have complaining only headache, but it is not grade 3 or above. Insomnia have been reported and also reported in a placebo effect. Nausea, respiratory tract infection, but is not in very high grade where they can interrupt the medication or stop. Then summary of the safety of the drugs, as we can see, there is no reported death, whereas drugs lead to interruption was only in 2, reduction only in 7 of the patient, and discontinuation only of the drug was in 4. So we can say that an energize or metabavate study demonstrated improvement or achieve the goal in primary and secondary endpoint was all have been achieved the goal, and there is a group improvement even in the subgroup analysis in those patients. For energize T, here they looked for transfusion-dependent alpha or beta thalassemia. It's the same scheme of the trial, except the double-blind period was extended 48 weeks. the exclusion criteria, inclusion criteria the same, exclusion criteria almost the same. And they looked at the primary endpoint. Here they look for the number of a transfusion reduction response, and it's defined if it's more than 50% reduction in the transfusion of the RBC or reduction more than two units in any consecutive 12 weeks period during the blind period, which is 48 weeks. And the secondary endpoints, they divided the transfusion reduction response to, there is 50% reduction from 24 period. Then we have TRR3, more than 33% reduction, and TRR4 is more than 50 reduction in 13 weeks till 48 weeks. And they look at the secondary efficacy, transfusion independent, defined as a transfusion-free more than 8 consecutive weeks through the week 48. The safety endpoint is the same as energize. And this is explain what we mean by transfusion reduction response, because we are not looking, hopefully we are looking in the future to be zero. But here they look at the duration and the number of units have been after they started or during the double-blind period. And we can see TRR, the transfusion more than 40%. Then TRR2, there is decrease, but still there is a number of it. So they define it as primary and secondary endpoint. The baseline demographic and disease characteristic is the same for both group. It was 2-to-1 including, and we can see from the primary endpoint, metabolism demonstrated statistically significant reduction in the transfusion burden for placebo, and almost 30% reduction. You can see even in the placebo arm, there was a reduction in the transfusion too, but on the metabolism, there was reduction in the numbers, more than 50%, which is good, keeping in mind those patients, they have a lot of complication from even the cardiology complications, as mentioned earlier, from the iron overload. And in subgroup analysis, all was in favoring metabolism arms from sub-analysis, from the age, from the sex, all was in favoring metabolism group. And here just to what we mean a reduction, when they are TRR2, there is a reduction in metabolism group more than 50% in transfusion at any consecutive 24 weeks. And with 36 weeks, there is 14%. And with 36, still, there was effect on transfusion rate reduction on more than 36 weeks. So a higher proportion of patients in the metabolism group, they achieved transfusion independence versus placebo, as we can see 90.9%. The side effect mostly reported is still, we have a headache, and more than grade 3, there was 0, but they reported respiratory tract infection, insomnia, and diarrhea, and fatigue was more in metabolism. So the summary of the safety is the same. The discontinuation was mainly around 10 out of the patient, dose reduction only 20%, and interruption of the drugs slightly, but there is no reported death or or a serious side effect in those patients. The most reported was concern of is liver monitoring, liver toxicity. Initially, there was concern. During the study, they kept repeating the LFT 6 months the first 6 months of exposure. In some of the non-transfusion dependent thalassemia and transfusion-dependent thalassemia with metabolism, they experience hepatocellular injury where the liver enzymes was increasing more than 5 And once the disease was whole, the drug discontinued, the liver enzymes came to be normal, and there was no damage to the liver or liver failure or death related to the drug. So in summary, the primary and key secondary endpoint of the study were met, and this is for Energize 1 and Energize 2. The primary and secondary endpoint, it was met for during the double-blind period, and efficacy was not driven by any pre-specific subgroup in this patient. And that was during the blind. The two study, they are still 5 years follow-up. This year, during ASH, we have two abstract follow-up from Energize T trial. And in this subgroup, with the transfusion-dependent alpha thalassemia subgroup analysis, 77% of patients, they maintain still the effect of transfusion from the reduction response of TRR2, 3, and 4 still they maintain the response, which is really good. Still, there is no lose of effect of metapavate in those patients. The other abstract, it is a long-term transfusion-free reduction impact on a transfusion-related burden. 17 patients of those who achieved during the protocol double-blind period transfusion independence, they kept it the same during the OLE period, which is now, I think it's almost 1 year. Those patients, they achieve 17 of patients, they are totally transfusion independent. So the maximum transfusion-free period during double-blind period was only 59.9 weeks, and the longest duration of a free period increased from 30 weeks during the double-blind and during the open-label period, as we can see in the graph. And the maximum transfusion-free period increased to 84 weeks with double-blind including and during the open-label period, which is still ongoing, this study. Thank you. This is the end of my talk.
Excellent, Prof. Farja. Thank you again for a great talk highlighting the latest update in therapeutics and thalassemia. So I think time for a discussion and open questions from our attendees. And thank you again for our attendees who are staying with us. So let's start with the questions from the attendees, and then we could have discussion among the panelists. We have a question here. What's the target range to keep serum ferritin and transfusion-dependent thalassemia with chelation therapy? Who wants to answer this question? دكتور سلطان تفضل.
طيب احنا بنعتمد على طبعا transfusion dependent thalassemia patient will always require chelation indefinitely. I mean the doses will be up and down, depends on liver iron concentration mainly and the cardiac iron concentration. Meanwhile, between these imaging, we rely on the serum ferritin. So we tend to reduce the dose if the serum ferritin drop below 1,000, but we don't usually hold the medication because the patient is going to be on continuous red cell transfusion. So around this rate. So those will be up and down when it's below 1,000. We'll cut it, but usually above that range, we rely much on the liver iron concentration. So serum ferritin is helpful as a trending for your chelation, that's not just single value. So the trending over, for example, 3-6 months, how it's going up, down, just to assess your chelation in general.
Absolutely.
The target liver iron concentration, we try it to be around less than 7 in general for patients.
Perfect. Dr. Dimitris, do you have any comment on this and for the cardiac
Yeah,
related to cardiac complications, please.
I mean, as Dr. Sultan said, that ferritin is just the trend. Of course, it is well correlated with liver iron, but there is no correlation between serum ferritin and cardiac iron. So serum ferritin is not at all predictive of what's going on in the heart. So for that, we need the T2 star, of course, the MRI. And we need to have an MRI above 20 milliseconds for the heart. And of course, even the serum ferritin drops below 1,000, as my colleague said, we still need to have some chelator going on into the blood because the patient continues to have blood transfusion. So we need some iron chelator in the body to take care of the extra iron that comes in with blood transfusions. So for the heart, we keep a look at the T2 star. We need this above 20, and there may be a disagreement between the T2 star in the heart and the serum ferritin, but this is expected. We may see that the ferritin goes down, but still the iron is in the heart, but it takes a long time for the heart to be cleared by iron compared to the liver.
Perfect. Great. Another question here. What's your experience in using thalidomide for transfusion-dependent thalassemia, as recent data showed up to 70%, 72% of patients with transfusion independent were transfusion independent after usage with a relatively safe profile. Prof. Farja, do you want to comment on this question?
Thank you. I didn't use thalidomide for my patient yet. We didn't have a proper RCT where I know some countries and in growing data using thalidomide for a patient, even with hydroxyurea, and there is decrease rate. But I didn't use it. I did use it thalidomide and other for patient who's like angiodysplasia, and it's work, they kept the hemoglobin, and they're doing fine. But I have no experience with patient in thalassemia.
I think with the available medication now, which is more safe, really we don't have to use thalidomide. I mean, thalidomide, I think, has been tested just to boost the hemoglobin F is one of the things that's used, but I mean, as a part of chemotherapy and risk of thrombosis, especially thalassemia patient at risk of thrombosis as usual. And I think we have options now that we don't really need to go that route with thalidomide.
I attend ASCT like not last year. They presented a study abstract, and they used it was one of the countries, and they use it in children. And I raise a concern of using in children, growing adolescents, male and female using thalidomide. I don't know the background to use it at this age. Maybe if they more than 18s, maybe there is a rule, but it's still in growing, but no, so far, RCT to more in favor, but there is data. There is a lot of abstract you can read, and some center they are using thalidomide, but I'll be cautious with children and adolescents to use it.
If I may have a comment on this.
Please.
Yes, very recently in TIFF we ran we formed a study group to check the case of thalidomide because it comes all again and again, and we were not able to find any true compelling evidence of the safety and the efficacy, of course. But so it is not an alternative to proper transfusion therapy. It is just a solution where of urgency, let's say, where patients cannot find proper blood transfusion. It's not an alternative. We should keep that clear. And TIF also is not going to support the use of thalidomide in any case because of the lack of compelling evidence. And of course, even better now that we have new drugs that are designed and studied towards this goal to increase the hemoglobin level, to reduce the transfusional needs. We do have now alternatives, but thalidomide is not an alternative to proper blood transfusion therapy. It is more like a solution in difficult situations, let's say.
Perfect. A question maybe to Dr. Farja. I mean, regarding mitapivat, I mean, when do you decide that, I mean, response is not great enough and you stop the treatment?
Excellent. The study is still ongoing. We have 5 years follow-up. But if there is a serious side effect, mainly from if there is a liver injuries, patient intolerance, then I will stop it. But I will give it time because during the blind was 48 weeks and the open label, it's 5 years, still ongoing the trial.
Perfect.
But my experience is some patient, which is still some patient, an improvement in hemoglobin is not tremendous. But if you look to the fatigue score, patient reporting quality of life, there was a lot of improvement in those patients. I think they were reported later on this, but so none of our patients, they stop it or they want to stop it even. They are on it and they want to continue the medication.
And how soon do you see a response or improvement in the hemoglobin?
Well, the response, and if it's non-transfusion dependent, it should be with 12 weeks. You can see the response. There is increase 1 gram. If it's a transfusion dependent, we are not looking at the hemoglobin response rather than the response on the how many unit and the duration between the unit. This is your target in a transfusion dependent.
Right. Dr. Dimitris, have you used it? Do you have experience in using it? And what's your input?
No, it is not used till now in Greece for thalassemia, but it's going to be approved very, very soon. So we do not have any experience with mitapivat thus far in thalassemia.
Right. How about luspatercept? Do you have it in use?
Yes, yes,
Yeah.
we use it. It seems that it is for not for a minority. It works in a minority of patients. It is often stopped because of adverse events like bone pains and so on. In many patients that worked, we had to stop it because of adverse events. So it's not a solution for the majority of patients. It works. It seems that it works in a minority of patients.
Right, right. Dr. Sultan, maybe about the allo stem cell versus gene therapy. I mean, in a nutshell, who would you give stem cell transplant and or gene therapy? I mean, considering again both are available, or
So
assuming both are available. Yeah.
in adults, gene therapy. I mean, the data for stem cell transplant was mainly pediatric patient up to, I think, the cutoff age of 17. Well, the results are excellent, but in adults, it's really inferior to what we've seen with pediatric. And that's why we adopted just to go with, even if there is a HLA match for adult patient with thalassemia, we proceed with gene therapy. So that's what we do, adopt. In sickle cell disease, yeah, it's a different story. If there is a HLA match, we go for gene therapy. Sorry, with the transplant first.
Right, right. I mean, both Sultan and Farja, have we used it in our centers? Mitapivat, I meant. Outside the clinical trial. I know some of our centers were part of this.
I have
Yeah.
two patients. Yeah.
Go ahead.
Yeah, I have two patients, one around 3 months now on the mitapivat. And we do monthly liver function test while we come for transfusion, no hepatotoxicity so far. One is just 1 month. So far, I didn't see any signals. We're just monitoring. We're going to continue for up to 6 months.
For us, because the company New Bridge is offering bridging programs where you can request it for patient who is eligible for it. We requested for 3 patients. Still, we will start. I have the experience with the drugs, mainly in the clinical trials, like Rise Up trial now ongoing. Maybe soon we will have report our real data on those patients after the bridging. We can explore it more.
Right. We have at least one patient also we're requesting request already ongoing, and hopefully we'll have it soon.
If I may have a comment, of course, we're expecting from you guys to have to listen to your experience because you were the first to approve it. So you will be the first to teach the others, huh?
Well, we're trying now. Requests are ongoing, so we're waiting for the drug to be delivered. One more question maybe before we conclude here to Dr. Demetris. I know, it's very important actually for this preventive program. I mean, focused again from your perspective on cardiac disease and having the T2 star on a regular basis and, having a regular clinic. I think that's goes in parallel, I guess, with what we have in terms of the advancement of therapies. I think it's a basic essential to have such management and multidisciplinary care. I know you already talked about this, but it would be important again to conclude with this and the importance of having such thing.
Yeah, I think that this is also outlined in the different TIFs documents. Multidisciplinary care is a must for all patients with thalassemia. This is a multi-system disease, as Dr. Farza presenting nicely in the first presentation. This affects every organ in the body. So to manage this, we need a multidisciplinary approach. We need the regular multidisciplinary approach, not wait until the problem comes up and then send the patient to the proper specialist. This we need to be proactive. And if I would like to talk like a cardiologist, also for the heart, this is very important because as I described during my presentation, heart disease results from the main disease and from the complications of the main disease, from anemia, for iron overload, for splenectomy, for complications from the liver, from the endocrine bloods. For example, in the past we used to have some cases with heart failure because of hypocalcemia, because of hypoparathyroidism, which is a complication of iron overload, actually. So everything converges to the heart, and everything, of course, affects all the systems in the body. So this is a multi-system disease. It's not just an hematological condition. It starts like an hematological condition, but affects everything in the body, particularly if the patient is not treated and followed properly. So we need multidisciplinary care, even if everything is okay, to be proactive and prevent.
Professor Asker,
Yes.
can you allow me just one question for Dr. Demetrius regarding your presentation, the drug medication. Do you think and prophylactic statin or needed for certain patient, or testing patient to find any plaques?
Well,
you will suggest for those patients?
Yeah, we do not use prophylactic statins. We actually, in patients with thalassemia, in most of the cases, we have very low LDL levels. So we do not have a target for statin therapy. But with the aging of the population and the aging of the vasculature, we start seeing patients with some plaques and so on, with some indications for statins. And then we start statins even with low cholesterol levels if we find evidence of atherosclerosis, but not without evidence and not without a proper indication for statin therapy according to LDL levels.
Okay, thank you.
Perfect. I think with that, we conclude our session. Again, thank you to our speakers for great presentations. The message, I think, is for both thalassemia intermedia and thalassemia major are both devastating diseases and leads to early mortality in those patients with a number of complications. The prevention management is the way to go, and we have different protocols for prevention. In addition, now we have therapeutics intervention to raise the hemoglobin and hopefully to prevent further complications of these patients, of these diseases. Thank you, and thank you to our sponsor, Newbridge Pharmaceuticals, and we look forward to seeing you in next webinar. Thank you, and have a good night, everybody.
Thank
Thank
you.
you. Thank you.
Bye.